Am I audible? Reshma ma'am, am I audible?
Yes, Hannah.
Okay, so first of all, I would like to welcome you all for the session, and Reshma ma'am, a warm welcome for you. And I'm handing over to Anusha ma'am to introduce our faculty. Ma'am, over to you.
Just a minute, Anna. Something is going on. I don't know.
Okay.
Good afternoon, everyone. Today, our topic is subcutaneous infusion. Our speaker, Miss Reshma, she has completed her BSc Nursing from Smith College of Nursing from Kerala and completed her CCPN course from Palliative, India. She has been associated with Palliative India since 5 years. Welcome, ma'am. Welcome for this session.
Thank you.
Ma'am, you can start.
Okay. I think my screen is visible right now. Is it visible?
Yes, ma'am.
Ma'am.
Okay, good afternoon to all. We all are well familiar with intravenous infusions and all, but today we are discussing something different from that, that is subcutaneous infusion. These are the layers of the skin. First one is the dermis layer, and beneath that there is a subcutaneous layer, then the muscular layer. Here we are discussing about subcutaneous infusion. So we are introducing something into the subcutaneous layer. It may be fluid or medications. And subcutaneous infusion is otherwise known as hypodermoclysis. The word itself means what it is. Hypo means just beneath, dermis just beneath the dermis. Clysis means slow infusion. So the hypodermoclysis means slow infusion of fluids or medication into the subcutaneous phase. And here the main thing is we are giving the isotonic fluids. We are only infusing isotonic fluids into the subcutaneous phase. Okay, what are the examples of isotonic fluids? What are the main isotonic fluids we are usually using in palliative care or in medical purposes? Okay, the main isotonic fluid that we are using is 0.9% normal saline. Dextrose is a isotonic fluid and a ringer lactate. And the main characteristics features of this isotonic solution is it has same solute and water concentration. The solute and water concentration is same for these isotonic fluids. That's why there is no fluid movement of water from cell water. So the cells remain same in size while we are infusing isotonic fluids. The main example for an isotonic fluid is 0.9% normal saline. And we also heard about hypertonic and hypotonic solutions. In hypertonic solution, what will happen is the main example for hypertonic solution is 3% sodium chloride. What will happen is it will draw water out of the cells into the bloodstream. So the cells will shrink. In hypotonic solution, the main example for hypotonic solution is 0.45% saline. And if we are administering hypotonic solution, the cell will swell, the size will increase. But the main component of isotonic solution is there is no water movement. So there is no size change in the size of the cells. And another point is we are giving subcutaneous we are giving subcutaneous infusions of isotonic fluids in subcutaneous space for mainly for rehydration purposes and to prevent the dehydration. The main point is we cannot able to introduce larger volume. If the patient is mildly to moderately dehydrated, we can choose this. If the patient is if the patient is mild to moderately dehydrated, we can choose this subcutaneous infusion. The main thing is we can only introduce small volume. Just a minute. Sorry for interruption. Okay, the what are the next is about the what are the main indications for subcutaneous infusion. The main indication, it is ideal for preventing dehydration. We already said it is mainly we are using for mild to moderate dehydration. If the dehydration is severe, we will choose for intravenous infusions. It is only ideal for preventing the mild to moderate dehydration. And if the patient is having severe dysphagia or swallowing difficulties or confused, we know in head and neck cancers, most of the patients will experience severe dysphagia and swallowing difficulties. That time, if the Ryle's tube insertion is contraindicated, then we can choose these subcutaneous infusions for preventing dehydration for that type of patients. And another important point is if the fluid need is less than 3 liters per day, then only we can choose subcutaneous infusion because we can only give smaller volume in subcutaneous infusion. These are the common indications of subcutaneous. Then what are the main indications in palliative care? How it is very important in palliative care means nausea and vomiting. We know most of our patients, cancer patients are receiving chemotherapy and radiation. After taking cycles of chemo and radiation, there is a chance to develop nausea and vomiting for that patients. And most of these patients are on opioids and all for pain management. Just imagine if a patient is on severe pain and we started with tap morphine for that patient. Patient is on adequate pain relief and all, but in between there is a need to take chemo and radiotherapy. After taking that chemo and radiotherapy, there is a chance of development of nausea and vomiting. Due to this nausea and vomiting, the patient can't able to take that morphine orally. So it will increase the pain. So that is a main indication in palliative care. If the patient is on opioid and due to nausea and vomiting, if they can't able to take that orally, we can prefer subcutaneous infusion for that patient. And another one is mouth, throat, and esophageal lesions. We know most of the head and neck cancer, some of the patients may experience fungating wound. There is a difficulty of RT insertion and all. So that time, if the patient is with large ulcer and all, if we can choose for subcutaneous infusion. Then next is about the intestinal obstruction. We know in intestinal obstruction, vomiting is a prominent symptom of a bowel obstruction. And where the bowel's contents are blocked, causing material to back up into the stomach. And this will lead to nausea and vomiting. And due to this, the patient can't take anything orally. And this may lead to mild to moderate dehydration. And if the patient is on some pain medication, they can't able to take orally. Like that, in intestinal obstruction, we can choose subcutaneous infusion. And if the patient is unconscious, we know if the patient is unconscious, they can't able to take anything orally. That time also we can prefer subcutaneous infusions for that patient. Then one important point is intractable symptoms that are not well controlled by oral methods. What do you mean by intractable symptoms? Any of you? What do you mean by intractable symptoms? Okay, intractable symptoms are signs of an illness or conditions that are difficult or impossible to relieve, manage, or cure with standard or conventional medical treatments. For example, uh, if the symptoms are persisting for a long, if we can able to control these persisting symptoms for a long period of time, it will significantly affect the patient's quality of life. Uh, if the patient is having intractable pain, means patient is on severe pain and that pain is does not responding to the usual medications. If the pain is not responding to the usual medications, it is called as intractable pain. Intractable vomiting means the vomiting is not relieving or there is no improvement in that with the current antiemetics. And some patient may experience intractable seizures. Intractable seizure symptom means that doesn't respond to standard anti-seizure drugs. This is what means intractable symptoms. The symptoms is not controlled by current available medicines or treatments. That is intractable symptoms. In that time, we can also choose subcutaneous infusion. Then rectal route is inappropriate. We already said in nausea and vomiting, most of our palliative care patients are undergoing through chemotherapy and radiation. And we also know if the patient is on morphine and if the patient is experiencing severe vomiting, that time they can't able to take that orally. If the patient is in home care, what we will advise is they can take that same dose of morphine per rectally. They can administer the same dose of morphine per rectally for that patient. The dose is same if the patient is taking tab morphine 10 mg orally for pain management and after chemotherapy the patient experience severe nausea, he can't take anything orally. At the same time patient in a home care settings. So that time we can prefer rectal route for the morphine administration. And we know constipation, some patients with opioids may experience chronic constipation and all. And if it is not treated properly, there is a chance of developing spurious diarrhea for that patients. In that type of conditions, we can't able to give morphine per rectally also. So the next choice is subcutaneous administration of morphine. So first we should find out what are the possible routes of administration. Here, if the patient is experiencing nausea and vomiting, we know the patient can't take anything orally. If we can give that rectally, we are next preferring that rectal route. And if it is also inappropriate or contraindicated for that patient, then we can choose for subcutaneous infusions. And next is about the subcutaneous sites. We know the commonly using giving medication subcutaneously is insulin. That all sites we can give, and we can give in the upper chest, that is intercostal plane we can give. Then upper outer aspect we can give subcutaneous injections. Then abdomen we can choose for subcutaneous infusion, outer thigh, upper back and scapular area. These are the some of the areas these are the areas we are choosing for the subcutaneous infusion. And sites contraindicated for subcutaneous infusions are if the area is having lymphedema. We know in CA breast patient, most of the patients are facing complications like lymphedema and all. And CA ovary, some of the patients may experience lower limb edemas. So if the patient is having lymphadematous area, we know in lymphadematous area, we are not allowing any when he punctures. So like that, if the patient hand is edematous, lymphadematous, we will not choose that area for the subcutaneous infusion. And if the skin site that have recently irradiated, then we are not choosing any brawny prominence. We will not choose for subcutaneous injections or infusions. Then in close proximity to a joint, it is not suitable for subcutaneous infusion. Then skin folds we should avoid. And if there is any inflammation or infection on this subcutaneous area, that we will not choose for infusions. In abdomen, if the patient is experiencing ascites or pitting edema, it is not suitable for the subcutaneous infusions or injections. And if there is any tumor, scarring, that area also will not, we are choosing for the subcutaneous infusion. And next we are discussing about the common medications that we can give subcutaneously. Any ideas? What are the medications we can give subcutaneously? What are the common palliative care medicines that we are using in palliative care we can give subcutaneously? Any idea?
MR,
Yes. What are the common medications that we are giving subcutaneously? Okay. Here are some of the medications that we can give subcutaneously is injection morphine. We know injection morphine is a common opioid that we are using in palliative care settings for pain management, breathlessness management and all. So we can give morphine subcutaneously. And some of other medications include haloperidol. We can give subcutaneously. Then midazolam. We can give injection metoclopramide. We can give subcutaneously. Then injection hyoscil butane bromide or buscopan. We are usually giving it for abdominal pain and all. So we can give that also. Then injection fentanyl. We can give. And we are usually not giving some medications like Stemetil, we will not give, diazepam. That means some oily preparations we are not preferring to give subcutaneously. We can easily give morphine, haloperidol, midazolam, metoclopramide, hyoscine butane bromide, and fentanyl. And we are not giving some antibiotics and some oily preparations and some powder form. Injection pantop we will not give subcutaneously. But currently, some of the institutions are practicing giving antibiotics also subcutaneously. We are not practicing. Some of the antibiotics called ceftriaxone we can give subcutaneously. Then ampicillin. But we are not practicing, so we are not much experts in this. So currently, we are only giving morphine, halo, midazolam. What are the medications we needed for the symptom control? We are giving. We are not preferring any oily preparations or any powdered for medications in subcutaneously. Usually, we are giving all these medications. And next is about the procedure. It is very simple, like intravenous infusions. We are doing all the procedure. First, you should explain the procedure to the patient. It is very important. Why you are choosing subcutaneous route of administration for that patient. That you should explain to them. It is while explaining, we should explain the advantages also. So we should explain the procedure, why we should choose. We are choosing subcutaneous infusion for that patient. Then wash hands. Then assemble fluid and tubing and prime the line with selected fluid. It is a basic principle, and we should use an aseptic solution for cleansing the area, and we should do in a aseptic technique. Otherwise, we are introducing infections. So the angle of insertion of needle is insert needle develop into the subcutaneous tissue at a 30 to 45 degree angle. This is the basics in this procedure. Next, we are going to play one video on subcutaneous infusion. Let's watch it and come back.
Reshma ma'am?
Can you please
Yeah,
spread it?
I'm trying. Is it visible?
Yes.
Okay.
Infusion of fluids or hypodermoclysis. Mr. Mahesh has advanced cancer of pancreas. Mrs. Lakshmi is his wife and caregiver.
Good morning, Mahesh.
Good morning.
I'm Nurse Sarjan. How are you feeling today?
I'm feeling very tired.
He is not eating anything, brother.
Doctor has advised to give on subcutaneous fluid.
Okay.
Requirements for the procedure: a tray containing one sterile tray with lid, sterile cotton swabs, one intravenous solution, normal saline 500 ml, one IV set, one SV set number 23, one pair of clean gloves, antiseptic solution, adhesive tape, one small Macintosh, one kidney tray. Check IV solution. Check the infusion container for sediments, turbidity, change in color and expiry date. Wash hands with soap and water and wear clean gloves. Remove the outer packing of IV solution container. Remove the protective cap at the entry point. Then remove the outer cover from IV set and remove the protective cover at the entry point. Spike the solution container with the IV set without touching the entry point. Partially fill the drip chamber by squeezing it till half. Remove the needle of IV set. Then release the roller clamp and allow the fluid to move through the tubings until all air bubbles have disappeared. Close the roller clamp and recap the needle and hang the IV solution. Open the scalp vein set and connect it to IV set. Allow fluid to move through the tubing to the tip of the needle. Disconnect the scalp vein set from the IV set and keep it in the tray. Provide a comfortable position and select the side, which are anterior aspect of upper arms, anterior chest wall, anterior abdominal wall, anterior aspect of thighs and scapular area. Place a small Macintosh under the arm. Cleanse the entry site with an antiseptic solution. Use a circular motion to move from the center to outward and leave it to dry. Take the scalp vein set and hold the needle by the wings. Remove the straight cap of the needle. Ensure the bevel of the needle is facing upwards. Pinch the skin with the non-dominant hand and insert the needle at 30 to 45 degree angle into the subcutaneous tissue. Release the pinch and support the needle against the skin with the non-dominant hand. Secure the needle to the skin with adhesive tape. Date and time should be mentioned on the tape. Remove the needle from the IV set and connect to the SV set using an aseptic technique. Release the roller clamp on the tubing and titrate the infusion to the prescribed rate. Infusion rate should be 1 ml per minute, that is 20 drops per minute. Bring back all the used equipments and dispose as per protocol. Ensure patient is comfortable. Document the procedure including the date, time, site, scalp vein set size and the patient's response. This finishes the procedure for subcutaneous infusion of fluids. Points to remember: maintain aseptic technique during the procedure. Check the site of infusion for signs of infection like pain or redness. If there are any such signs, the infusion site needs to be changed. If there is no signs of infection, the site of infusion can be used for up to 7 days. Normal saline is the most suitable IV solution. 500 ml to 1500 ml of fluid can be administered over 24 hours at one site. The quantity of fluid to be given depends on the needs, the general condition of the patient, and the stage of the disease. The mild edema in and around the site of infusion is normal. Subcutaneous infusion can be safely given in home care settings also. The caregiver needs to be trained in handling the infusion after it gets over.
Reshma ma'am?
I think the procedure is clear right now. Is there any doubt in this procedure? This is how we are giving subcutaneous fluids to it. We are introducing subcutaneous fluids. And okay, now I am going to explain the process of absorption. We know after the injection or administration of these fluids, the fluid initially disperses throughout the subcutaneous tissue and causing the tissue to expand. That's why the edema is occurring. First, what will happen is, if after injection, the fluid initially disperses throughout the subcutaneous tissue, and through the process of diffusion, the fluids moves from the injection site to the surrounding interstitial space. Through the process of diffusion, the injectable fluids moves from the injection site into the surrounding interstitial space, and from this interstitial space, the fluid is absorbed in the blood capillaries and also enters the lymphatic vessels. First, we are introducing that fluid into the subcutaneous space. The fluid initially disperses throughout the subcutaneous tissue and causes tissue expansion. And through the process of diffusion, the fluid moves from the injection site to the surrounding interstitial space. From this interstitial space, the fluid is absorbed into the blood capillaries and also enters the lymphatic vessels. And these capillaries will transport the fluid directly to the systemic circulation. This is what is happening after we are giving a subcutaneous fluid or medications. After injection, the fluid initially disperses through the subcutaneous tissue. This will cause the tissue to expand. After this, the fluid moves through diffusion process. The fluid moves from the injection site into the surrounding interstitial space. And from this interstitium, the fluid is absorbed into the bloodstream and the lymphatic vessels, and from these capillaries transportation, the fluid directly enters into the systemic circulation. That this is the process of absorption happening in this subcutaneous infusion. And another thing is, there is a natural substance found in this extracellular matrix is hyaluronic acid. Hyaluronic acid is a natural substance that found in the extracellular matrix. The main function of this hyaluronic acid is act like a natural barrier, and it will act as a natural barrier, and it will prevent the rapid flow of fluid through the tissues. It will act as a barrier and it will prevent the rapid flow of fluid through the tissues. If once we are introducing an enzyme like hyaluronidase, it is an enzyme called hyaluronidase. While we are inserting this hyaluronidase subcutaneously, it will break down that natural substance hyaluronic acid, and it will creating a temporary channel to the fluid and other tissues. So the absorption will increase if we are giving enzyme hyaluronidase. This is one of the important point. There is a hyaluronic acid. It is a natural substance that exists in the cellular matrix that is there. It will act like a barrier and it will prevent the rapid flow of fluid through the tissues. If when we are giving enzyme hyaluronidase subcutaneously, it will break that hyaluronic acid and it will allow the easy movement of the fluids within the subcutaneous space. So we can give the infusion, we can induce easy absorption of the subcutaneous fluid. Generally, there is hyaluronic, it is a formulated medicine and we can, it is available in injectable forms. And next is about the volume and rate. We already know this subcutaneous infusion we can choose only for mild to moderate dehydration. Mild to moderate dehydration we can give. The important point is we can only give 1 ml per minute. That is 20 drops per minute. If we are giving more than 20 drops per minute, the patient may experience large edema over the infusion sites or there is a chance of leakage. So we can only give 1 ml per minute or 20 drops per minute. That is the volume and rate. And in one site, we can give 1.5 liter over 24 hours. That is the maximum we can give in a single site. If you want to give more than 1.5 liter for a patient, you should choose another subcutaneous. So in one site, we can only give 1.5 liter for 24 hours for maximum dose. So in two sites, we can give 30 liter over 24 hours as a maximum dose. This is the volume and rate. It is very important. If we are giving more than 20 drops per minute, patient may feel severe pain and there is a chance of leakage. The edema is more. So the volume and rate is very important in subcutaneous infusion. And the main advantage, okay, there is a post procedure and we should instruct the patient, do not set the drip rate to deliver more than 1 liter in 2 hours. We should instruct them not to give the drip rate to deliver more than 1 liter in 2 hours. And after giving the infusion, you should document the infusion fluid or medication in the infusion chart. What medication you are giving through subcutaneously. And you should check the patient and infusion after 1 hour to ensure that the infusion site is correct. Is it correct or not? Or there is no signs of edema, leakage. If there is large edema and leakage, that means you are giving more than 20 drops per minute. You are giving more than 20 drops in a minute. So if necessary, the infusion site can be massaged to enhance edema absorption. If the patient is experiencing more edema and if you are giving only 20 drops per minute, slight massaging will relieve that edema. And what are the main advantages of subcutaneous infusion? It is low cost. We know one IV cannula, it will cost very costly. So, but here we are using scalp veins for mainly for subcutaneous infusion. We are practicing with scalp veins. It is low cost and it is more comfortable than IV administration. Because we are not inserting anything intravenously. So it is more comfortable than IV administration and less likely than IV administration pulmonary edema or fluid overload. Because here we are only giving 20 drops per minute. So the chance of pulmonary edema or fluid overload is very, very rare in subcutaneous infusion. So it will not cause edema, pulmonary edema or fluid overload. And it is very simple, very easy and very simple to insert. Anyone can do this. And it is less distressing than IV and easier reinsertion at a new sites. If the caregiver is trained on this, they can easily relocate the site. And it is more suitable for home care than IV line with less staff supervision. We know IV cannulation is mainly doing by a healthcare professionals who is trained in doing that specific procedure. But in this subcutaneous infusion, they only need a supervision. Anyone can insert subcutaneous infusion with less supervision. So it is a most preferable route of administration of medicines in patients with home care. And do not cause thrombophlebitis because we are not inserting anything into the intravenously. So there is no chance of formation of thrombophlebitis. And it has been show cause septicemia or systemic infections. There is no chance of septicemia or systemic infections. We are not inserting anything intravenously, so the chance is very less. And we can be started and stopped at any time or no danger of clot formation. If we are putting an IV cannulation, it is important to maintain that IV cannulation without any clot formation is very important. Otherwise, the patient may feel pain while we are giving medication. So this is there is no chance of clot formation in subcutaneous. So we can easily give medications to that patient. And these are some of the advantages. It is very low cost. It is comfortable than IV. It will not cause pulmonary edema or fluid overload. Simple insertion, and we can easily find another site also. It is more suitable in home care settings, and it need less staff supervision, and it will not cause thrombophlebitis, and there is a chance of septicemia and systemic infection is very, very less, and we can start and stop at any time. These are some of the advantages. There are some disadvantages also. Some disadvantages include there is a chance of possible irritation and inflammation at infusion site. There is a chance of irritation and inflammation at the infusion site if we are not following an aseptic technique while inserting the subcutaneous infusion. And there is a chance of possible leakage of subcutaneous site. Usually the leakage occurs when we are giving more than 20 drops per minute. If we are giving more than 20 drops in a minute, there is a chance of fluid leakage. Then allergic reaction, it is very, very less. Here we are using subcutaneous and the allergic reaction is very, very less. And next is about some of the side effects. Some of the side effects and complications include, there is some potential complications include localized edema. The patient may experience localized edema. The edema around the site of insertion of the subcutaneous infusion, and it usually resolves spontaneously with massage. If we are noticing an edema over the infusion site, just give a gentle massage on that area. It will spontaneously resolve. And next is about the inflammation or cellulitis. Usually the inflammation and cellulitis will cause associated with poor insertion technique, or we are not properly maintaining strict aseptic technique during the subcutaneous insertion time. It may cause inflammation and cellulitis. And pain and discomfort at insertion site is another potential complication. But it is very rare, but can be associated with fast infusion rate. We know we can only give 1 ml or 20 drops in a minute. If we are giving more than that, the patient may experience pain and discomfort. Then Then puncture of blood vessels during insertion. It is very, very rare because we are inserting and placing that needle to a subcutaneous space. So it is very, very rare. If you are noticing any presence of blood in that scalp vein, just remove it and place another scalp vein on the subcutaneous tissue. And then if you are noticing any blood or blood flow in that subcutaneous line, just reset the subcutaneous device. Then hematoma around the insertion site. That is one of the potential complications. But it is very rare if the patient is getting low platelet, patient is associated rare. If there is hematoma, it means the patient is associated with low platelet, or if the patient is receiving anticoagulant therapy, there is a chance of formation of hematoma around insertion site. So it is if the patient is having low platelet or receiving any anticoagulant therapy, there is a chance of formation of hematoma. Then infusion device occlusion. Infusion device occlusion is very rare. Ideally causes in kinking to the external tubing. If there is any kinking to the external tubing, it will cause occlusion. These are some of the common side effects of subcutaneous infusion, and there are some nurses' responsibility also. The nurse should inspect the site every 4 hourly. The nurse should inspect the site every 4 hourly for any tenderness or hardness at the site. If the patient is having any tenderness or hardness at the site, they should check for that. Is there any presence of hematoma? We already said if the patient is having low platelet or they are receiving any anticoagulant therapy, there is a chance of hematoma. So while checking the insertion site, we should check for any presence of hematoma. And you should check for any leakage at the insertion site. The leakage, if there is any leakage, that indicates you are giving more than 20 drops in a minute. So if you are finding any leakage in that infusion side, just slow down the rate. Just reduce the rate of infusion and watch for further leakage. And if the patient is having pain also, this is the same way you are going to manage. Just slow down the infusion rate. Then you should check for the local tissue irritation. Is there any color change or there is any change in temperature? That also you should check. Then erythema, there is any redness, you should check for that. And if there is a presence of blood in the tubing, means the subcu site is not in proper place. So you should check for the presence of blood in the tubing also. And displacement of cannula. If it is displaced, not placed properly, it will also cause irritation. So just palpate through the skin. You can feel the needle tip. That's how we are finding the displacement of cannula. So the main nurse's responsibilities include the nurse should inspect the site every 4 hourly for tenderness or hardness at the site. Is there any presence of hematoma is there? Or leakage of the insertion site is there, it indicated that if you are giving more than 20 drops in a minute. And if there is any local tissue irritation, you should check for that. Or erythema, any temperature variations is there, you should check for that. Then presence of blood in the tubing indicates if there is any blood in tubing, means it is not in the proper place. It is not subcutaneously placed. And displacement of cannula also you should check. And these are about, and these are the syringe drivers we are using here at Palliative for giving subcutaneous infusions. And in this, if the patient is in end of life, we can give palliative sedations through this syringe drivers. We are usually giving morphine, fentanyl, haloperidol, midazolam, all through these subcutaneous syringe drivers. We can connect it subcutaneously and intravenously. For subcutaneously also it is suitable, and we can load the syringe with medicines whatever we needed for the infusion, and we can give like fluid only we are giving these medications. These are the some of the syringe pumps we are using for palliative patients. And like that, we already discussed these points. Post-procedure, we do not set refrigerate deliver more than 1 liter in 2 hours. And we should document the infusion or what we are giving through that subcutaneously. Check the patient for any edema, leakage and all. If there is edema is there, we can give slight massaging. And some of the disadvantages we already explained. There is a chance of possible irritation and inflammation at the infusion site. And if we are giving more than 20 drops in a minute, there is a possible leakage of subcutaneous site. Then allergic reaction is very, very rare. And nurse's responsibility includes these points. You should inspect the site every 4 hourly for tenderness, hardness, presence of hematoma, leakage, local tissue irritation, erythema, redness. Is there any presence of blood clots? Is there any temperature variation and displacement? And this is all about subcutaneous infusion. Okay, if you want to clarify anything, please ask.
Dear participants, if you have any doubts, please ask them. Ma'am is here. Doubts? No one
Thank you,
is
madam.
responding. Please tell me.
Madam, how is the effectiveness? If you give subcutaneous infusion, how is the effectiveness then is there compared to IV or other mode of infusion? It is very good or
Sir, in Pallium, we are usually using subcutaneous infusions for all of our patients, most of our patients, because most of our patients after getting chemo and chemotherapy or radiation, it is very difficult to get a patent IV line. So we are mostly preferring this, but the pain relief is adequate as same as intravenous, but it will take some time, sir. If we are giving morphine intravenously, it will act within 10 minutes. But if we are giving morphine subcutaneously, it will take 15 minutes, sir. It will take some time, but the effectiveness is same, sir. Here we are usually using morphine syringe drivers for giving subcutaneous infusion. We are giving palliative sedations and all through subcutaneously.
thank you, madam.
Yes. The onset of action is different for some medication. If we are giving fentanyl intravenously, it will take only 3 minutes to act. But if we are giving fentanyl subcutaneously, it will take 5 minutes. That is the only difference.
Thank you, ma'am. It's a wonderful session we got. Thank you so much.
Thank you, ma'am.
Thank you, ma'am. Thank you for the insightful session. And dear participant, thank you for participating. And we can wrap it up for today. We can leave now. Thank you, ma'am.
Thank you, Anna.